Well, hello, everyone. Welcome to the Immunocompromised and the Coronavirus Congressional Briefing. My name is Lynelle Bezo, and I'm with the Immunodeficiency Foundation. The agenda, we're going to include an overview of the collaborative. Then we're going to hear 3 powerful community member stories, and then have a policy panel discussion, and then Q&As. Some background on the immunocompromised. We define immunocompromised as those with primary and secondary immunodeficiencies. These groups have always had to take exceptional precautions, but their needs have not always been recognized by policymakers. COVID-19 has highlighted the importance of considering our perspectives. Primary immunodeficiencies, or PIs, include over 400 conditions in which the immune system fails to function because of genetic or intrinsic details. This slide lists just a few. People with PIs are highly susceptible to infections, which can ultimately lead to organ damage and other critical conditions. It is linked to autoimmune diseases and increased risk of cancer. For many with PI, the treatment is immunoglobulin infusion therapy, which is derived from plasma and provides antibodies that the body is generally unable to produce. Some people with PIs do not produce sufficient antibody response for vaccines, so they rely on herd immunity to be truly safe. And this is not just from COVID, but from other pathogens such as measles. Newborns with SCID, which is one form of PI, are born without a functioning immune system and require bone marrow transplants or gene therapy. And you're going to hear more about SCID from Rachel's story later in the presentation. So on secondary immunodeficiencies, these are conditions that result in weakened immune systems from external factors such as illness or treatments, including chemotherapy, radiation, biologics, and immunosuppressants. Conditions include those listed on the slide, and you'll hear more about lupus and HIV later. So the collaborative is the Protecting the Immunocompromised Collaborative was formed this past spring in response to COVID-19. The steering committee includes Immunodeficiency Foundation, the AIDS Institute, the American Autoimmune Related Diseases Association, ARDA, the Lupus Foundation of America, and Susan G. Komen. And you can see on our website, which is at immunepolicy.org, the letters and actions that we have taken. We're now engaging with a broader group as part of the collaborative. On this slide, you can see our priority issues, which include vaccine prioritization and uptake, reopening options, and other issues that we'll discuss today. In regards to vaccine prioritization, we have done outreach to Congress, the Academies of Medicine, and the CDC. And as you can see, I've listed here immunocompromised conditions that the CDC has listed as increased risks or might be at increased risk related to immunocompromised issues. Now I'm happy to begin our community member story panel. We have with us Rachel Homer, Monique Gore-Massy, and Janet Kitchen. And Rachel will be our first presenter. Rachel is the proud mom of Lameria, who is born with SCID and has gone through quite a journey getting her daughter into treatment during the pandemic. Rachel and her family live on the Navajo Reservation in Arizona. And Rachel, why don't you tell us your story?
Hello, my name is Rachel Homer, and I live with my husband, our 4-year-old son, Lucius, and our 20-month-old daughter, Lameria, in Kaibito, Arizona, on the Navajo Reservation. When Lameria was born July 20th, 2019, we discovered through newborn screening that she had severe combined immune deficiency, or SCIDs. Doctors told us while she looked normal, she did not have a functioning immune system. And without treatment, her body would not be able to fight infections. She would not be able to survive. With a gene therapy transplant, Lameria had a chance to live a long, healthy life. And to prepare her for the surgery, we had to travel to San Francisco and admit her to the UCSF Children's Hospital. Once we arrived to the hospital, she had to be isolated and free from any germs. When Lameria was 3 months, she had her transplant, and after a transplant, it takes a while for a child to build the necessary antibodies they need to fight infections. We spent 9 months in the hospital, and once we were released from the hospital, the pandemic started. We had to stay 1 month in San Francisco, and then we returned home on the reservation. When we returned home on the reservation, we had to be very careful to keep from any viral or bacterial infections, not just COVID. We are lucky that we have a home with running water, electricity, and internet. There are some families here who are not so lucky. My husband has a job as a parts manager, and to make a living has to go to work every day. Unfortunately, a few months ago, he did test positive for COVID-19. As you may have seen on the news, our community was hit very hard by COVID-19. To keep my daughter safe, we had to isolate my husband to the master bedroom and bathroom, while the rest of us lived in the other 2 rooms. While the procedure was life-saving, Lameria still needs ongoing medical treatment and monitoring. At first, I had to give her GCSF injections, which she doesn't need anymore. We have to take her to the doctors every 4 weeks to receive IVIG, blood test, and to be examined. Tbilisi City Regional Health is 45 minutes from where we live, and we've gotten used to making this trip frequently. The doctors have implanted a port on her chest so they don't have to stick her with the needle every time she receives IVIG. With the port, we have to be very careful to not get any infections. There are many challenges that people in my community face, especially during the COVID-19 pandemic. Having a child who's immunocompromised is another challenge. I am grateful to the doctors who have treated my daughter and will follow her as she grows over the years. Ensuring that the Native American reservations have resources to provide for an immunocompromised child is essential.
Thank you, Rachel. And next, I'm going to have Pat Wildman of the Lupus Foundation of America introduce Monique Gore-Massy.
Thank you, Lynn, and good afternoon, everyone, or good morning, depending on where you're from. I have the distinct pleasure of introducing Monique Gore-Massy. Monique is from the New York City, New Jersey area, actually just had a move. But Monique's been living with lupus for more than 10 years. And during that time, she's been a tremendous advocate despite all the challenges of living with lupus, and it really has impacted her entire life. So I wanted to turn it over to Monique and share her story.
Thank you so much, Pat, and thank you all for taking the time to join us today. This is such a meaningful and essential time for us. You're meeting with me. I'm someone who is now known as a national lupus advocate and also a global lupus and patient advocate, but I'm also someone who is just a regular person. I fight for equitable and accessible care for patients like myself with rheumatic and autoimmune diseases. I had a pre-lupus life, and it's important to remember that this life now is almost like an alternate reality. In 2010, I heard 3 words that inevitably changed the trajectory of my life. The doctors told me that I have lupus. I was not familiar with lupus. I didn't know anyone with lupus. I walked around for almost 2 years in the big metropolis of New York City, trying to figure out what was wrong with me. I bounced around for about 2 years, going from emergency room to doctor visits to urgent care, and I could not get one diagnosis that led me to lupus. So many other things came along, and I just figured I would take whatever it was that they gave me so that I could live. During that time, I became engaged to a wonderful gentleman who is now my husband. I'm proud to say that. He's been with me during this paradigm shift that lupus created. It was explained to me that lupus is an autoimmune disease to which there is no cure, and it can be potentially dangerous and have deadly complications. I became too familiar with hospitalizations and obfuscating issues that included but were not limited to disability, discoid rashes, gastrointestinal abnormalities, mental health challenges, several infections, both viral and bacterial, lymphatic tumors, vasculitis, pericarditis. I was susceptible to everything under the sun. And then when they told me that I was dealing with lupus nephritis, which seems to be the most invasive and cause flares, it was seeming to be terminal for me. My team did everything that they could to save my life. From then until now, I've been through several procedures. I've been administered chemo. I've had surgeries. I've been on as much as 15 to 25 medications per day as my standard of care while taking biologics, while taking chemo. During this time, I became eerily familiar with what we all know now as what it means to be socially distant. Also, I heard the term and experienced quarantining over the years. I lost touch with society. I was no longer able to work. I lost touch with friends. I lost many different opportunities. I knew what this new term now everyone else is now familiar with. I was living as an immunocompromised / immunosuppressed individual, especially due to the medications that I was on. I lived in shame, I lived in fear, I lived in grief, I lived wondering if I would survive from day to day. I fought with the insurance companies. My husband and I dealt with denials after denials and trying to get medication. We fought with SSDI and trying to get approval for insurance. We are still fighting to find out about approval for the 9/11 compensation fund. Lupus did not seem to be on anyone's mind. I didn't feel validated. I didn't feel like a member of society. During the hills and valleys of that time, I found the Lupus Foundation of America, and it's nothing but God that I'm here to share my story with you. They were a conduit. And I see that leading us to where we are in 2020. It marked an inflection point in patient-centric approach. The Lupus Foundation definitely took the charge in making sure patients were educated and informed about what was happening during the pandemic. We saw many of the symptoms that were being expressed very similar to what we live with lupus every single day: extreme fevers, chronic fatigue, trying to catch your breath, dealing with ulcers, weight loss, conjunctivitis, nausea, dizziness. We often hear about the brain fog. As a lupus patient, I know that very clearly. We have hard times with the pain and with excruciating changes in what we're allowed to do and what we can do for that day. When COVID hit, I felt like it was a strange and eerie reminder that life is just not normal for a patient like myself. Life is not normal for myself or my husband or my family members. We were left to have to quarantine, my husband and I, in a bubble. I was not able to see my immediate family members. They carried on with life. They socially distanced while they went out, and our whole livelihood was upended once again, just while I felt like I was beginning to hit my stride, just while I felt like I was beginning to become an integrated member of society. Access to care became strained. I wasn't able to get to my doctors. That's imperative for someone like myself living with lupus. My doctors needed to put actual eyes on me and to administer care to me live and in person. It became very, very fearful for me to go out and get intravenous treatment or to even go to my doctors, which were no longer available. The technology known as telehealth offered an option, but having not great Wi-Fi in my area was not always the best option. I understood that being immunocompromised would make me more susceptible, and I had been living in this sort of bubble of being afraid to hug people, of being afraid to shake hands for almost 10 years. And so it really hit me to the core. It really felt like a just brutal, brutal reminder that lupus will be with me until the day that I go. But it also provided a sense of opportunity and hope that I could share with others and how to live and live more abundantly. During this time, patients like myself experienced shortage of hydrochloroquine, which we now know as HCQ. It proved to not be effective in solving the mystery of COVID, but it was effective for patients like myself. It was a lifeline. I searched all over high and low, and it took me months to get access to HCQ, which happened to be in California. And I'm asking that everyone that hears our story, that you realize that patients and partners like Rachel, like Janet, we are meaningful in making decisions and changing policy. What's happened with COVID is just one inflection point of a life that we've been living. We don't want to live on the fringe anymore. We don't want the world to move on and open up without us. We would like accommodations in trials. We would like to know that medication will be readily available to us in the same innovative way that medications and vaccines became available for COVID patients. Lupus patients would like to know that they have options, especially when HCQ became dwindled. We would like to know that we're protected and that we're covered under exclusionary screening sometimes because they mirror COVID symptoms and the lupus symptoms. Accommodations that suddenly became available during the pandemic, we ask that they stay available for us as we continue trying to live integrated in society and no longer on the fridge. Please don't leave us behind. See that we are here. See that our lives are worth matter. See that the innovative research and groundbreaking treatment is also something that we are calling out for, and for your availability in this area. Thank you so much.
Thank you so much, Monique. I think so many people can relate to what you just shared from all the different immunocompromised conditions. And now I'm going to introduce Nick Armstrong from the AIDS Institute, who will introduce Janet Kitchen, and she can share her story as well.
Great, thanks, Lynn. And it's my pleasure to introduce Janet Kitchen. Janet is the founder of Positively You, Inc., which is a nonprofit community-based organization in Central Florida, which is led by minority citizen activists and staffed by a majority of people living with HIV. Janet, who is a person living with HIV herself, is a fierce advocate for people living with HIV. Through her work, she fights HIV stigma, works on HIV prevention, and really supports and organizes women living with HIV in her community. She's received many awards and accolades, one of them the 2012 Shiro Award from the National Minority AIDS Council, and has also been featured in Pause Magazine's list of most amazing people living with HIV. So it's my pleasure to introduce Janet, and I'll let her take it away.
That was my cue to get off mute. Good afternoon, everyone, and thank you for allowing advocates here to speak out and speak their truth and to give a voice to those that the communities that we represent. As Nick said, I am a woman living and surviving of HIV. I've been HIV positive for 16 years. I am also duly, diagnosed. I am a breast cancer survivor of 23 years. The breast cancer came first. HIV now is my new life, although I still advocate and for those that are diagnosed or even now survivors of breast cancer. I was diagnosed back in 2005. It was a very trying time. HIV, although it is an immunocompromised illness, we try to bring that home or try to eliminate the stigma by saying it's a chronic illness. However, although it's chronic and manageable, there's a lot of other barriers that one, I would say, prevents from care. And we all know that starts with stigma. Stigma is usually the reason why one will not go into care. Other illnesses are found to be nice, I could say nice or quaint or inviting. HIV usually isn't. It's usually all created with or associated with something that you may have done wrong. So when I was diagnosed in 2005, I was unable to get medication. And the reason for that is where my journey of stigma started. And that was because I had insurance. However, the insurance that I had, I'm a former retired government worker, it did not cover the cost of medication. At that point there, I realized and the door was open into this new life I have as a woman living with HIV. I was told that I could not get insurance because I had worked or I had some insurance. I actually had to fight for, and I was what was diagnosed as AIDS. I had to fight about 6 months to finally, because this whole system of nuancing and trying to navigate was very, very difficult. I was able to get medication, and the thought came to me, if I, a retired federal worker and an educated woman, if they can treat me like this, what would they do to those that don't know? Hence started my journey in advocacy for people living, not just necessarily women, but people living with HIV. Having those being able to embrace their new life, having them also being able to understand that HIV was not a death sentence, that it's a life that we have, but we have to be able to live with it. But I realized too that there were a lot of inequities living with HIV that stopped them from having access to care. And access to care is usually our issue that we have, that we need to make sure that we get life-sustaining medication. So once medication came about, and we now are on a 1 pill a day, which is very, very easier. It now, with our compromised system, stopped us from the continuous diarrhea, from the vomiting and all the other issues that we had to deal with living with HIV. But today I want to say that because of the adversity and knowing what it was to be discriminated against and stigma, I started an organization. My organization is Positively You. And Positively You means positively you can be HIV positive, you can have lupus, you can have diabetes. It really is a spectrum of living in a positive life with whatever adversities you have as far as health. I have expanded Positively You. We're in 5 different locations, and I've trained advocates to be able to live a healthy life living with HIV, teaching them how to eat healthy and have the tools that they need to eat right, be able to exercise. And I've also bound a social network where we can get together and embrace each other and kind of beat the stigma that's out there for us. I think that HIV, out of all illnesses, is something that one thinks has gone away, which is the worst thing in the world, because of that thinking, that ideology, HIV is spreading more, but it's such a quiet secret, and more that we need more information, we need more advertisement, we need more media to speak about it, we need more education in the community. So what I would like to say, as far as immunocompromised, we need to make sure, especially during COVID, my brothers and sisters that are living with HIV, we too had to be isolated and not be around others, because we too, because of our immune system being so compromised, had to be in isolation. And during that time is when I too realized, like Monique said, we had to be able to have some way of communicating with one another. So we set in mechanisms at Positively You to do that. And I think I want to just end by saying being immune compromised sometimes is already isolation in itself. And we need to talk about that more. And as I say in Positively You, make it a household word. Thank you.
Thank you, Janet. And that's a really good point that we've heard a lot from our community as well, that, a lot of the things that people are facing now, that everybody's feeling isolated, is something that people who are immunocompromised face all the time. Now I'd like to introduce our policy panel. And if you guys want to come on screen, I have Pat Wildman from the Lupus Foundation of America, Nick Armstrong from the AIDS Institute, and Molly Guthrie from Susan G. Komen. First, I'll start with Pat from the Lupus Foundation. And you just heard from Monique, and Pat is going to give you some more deeper dive about lupus and some of the policy issues that they've encountered and have tried to address. Here you go,
Thank
Pat.
you, Lynn. Appreciate it. So I just want to share a little bit more about lupus. Monique really, certainly put a face on this disease, and I want to tell you a little bit more about the disease and also about some of the challenges that people with lupus have faced during the pandemic and some of the concerns that we have going forward. First, lupus is a chronic autoimmune disease in which the immune system attacks healthy tissue, and that results in tissue damage, organ damage. As Monique shared, the symptoms can vary quite a bit, from pain, extreme fatigue, hair loss, cognitive issues. Monique mentioned brain fog, and a wide variety of different impairments. It can impact any part of the body, whether that's the skin, kidneys, cardiovascular, any part of the body. And it's certainly disabling, debilitating, and it can be fatal. And the other thing that's challenging with lupus is that it's very difficult to diagnose because it mimics other conditions. It takes about 6 years on average for someone to get a lupus diagnosis. And once they are diagnosed, the treatments are many. Monique shared she's been on more than 20 at a given time. So that is not unusual. So the burden of treatment is significant in lupus. And there are up to 1.5 million Americans living with lupus in the United States. 90% of them are women. But in the disease impacts generally people in middle age, from age 15 to 44, but age, it can happen at any point in someone's life, including younger or older. And we do know that lupus impacts minority populations disproportionately. So up to 3 times more likely to develop lupus in African American women, Asians, Native Americans, Hispanic. And that's an important factor because we do see certainly disparities in COVID. And because of the challenges with lupus, because people with lupus are immunocompromised, they're at greater risk of any infection, whether that's COVID, whether that's flu, whether that's a common cold. They're already at risk. And that means they're certainly at greater risk of COVID. And it's both because of the disease and because of treatments. People with lupus take immunosuppressants, steroids, monoclonal antibodies, things that suppress the immune system. So both the disease itself and the treatments can increase risk of COVID, and also more severe COVID. And part of the challenge there is also there are other conditions that are common in lupus, whether it's hypertension, kidney disease, challenges with heart and other organ systems that increase risk of COVID. So in addition to lupus, there's these other underlying conditions that increase risk. And Monique shared some of the challenges that she has faced, and they're certainly not unique to necessarily to the lupus community when it comes to getting out into the community, work, school, and things like that. But with people with lupus, and this was, Monique shared that it's kind of, when the pandemic began, it wasn't all that unusual for people with lupus knew the term social distancing. They were used to, practicing safe practices, hand washing, staying away from people who are sick. But with COVID, it was really it went to a different level. And even it became worse when we had the issues with hydroxychloroquine. Now, those issues have been solved. There are a lot of different challenges when hydroxychloroquine was looked at as a potential treatment for lupus. But there are concerns out there about what happens when there's either another pandemic, another situation like this, when they're looking at other medications for whether it be for lupus or other conditions. What happens to those communities? And lupus was a significant challenge. People unable to access that medication. But that certainly hasn't been the only challenge that people with lupus have faced. Accessing care has been a hugely important thing, but also a big challenge, whether that's physicians, and Monique was talking about the need to get out into the community or to the physicians to get treatments. Of those 20 plus medications, some certainly you can get at the pharmacy, but others you have to go get infused. So you have to get out into the community. Telehealth and telemedicine has provided an important option, but it shouldn't be and it can't be the only option because there is a need to see the physician. There is a need to get infusion. And also there's challenges in communities about technology and getting access to telemedicine. We certainly have seen some challenges when it comes to the research side of things in clinical trials. I think the other presenters will share a little bit more about some of the clinical trial challenges. A couple of other challenges I wanted to share. One is we've already talked about the symptoms of lupus do mimic COVID. Now that's created a couple of things, and I'll get into another one in a second. But one has to do with people with lupus are continually questioning whether it's COVID or lupus. And that has created a number of challenges. One of people having to go get tested, get out into the community, get tested, which increases their risk. So, and then also certainly, I think all of us have in some way impacted our mental health. And with lupus, that's even greater. Living with the challenges of lupus itself and the increased risk in this time, it can be overwhelming. So certainly we've seen elevated mental health challenges out there. And then when it comes to reopening, there are some unique challenges that I think it's really important for folks to keep in mind. One, that because of the increased risk of any infection, it's important that people with lupus continue to have remote options, that they continue to either, whether it's school or work, continue to do those things remotely. But the other thing too is I think we've seen a lot when we go out into the community, there's a lot of screening questions if you go into a building, whether it's work or school. And those screening questions, a lot of the things they're asking, whether it's fever, sore throat, aches and pains, things like that, while those are symptoms of COVID, they're also common in lupus. We want to make sure that as things do reopen, when they do reopen, and that there are these screening questions, that they don't unfairly discriminate against people with lupus and prevent them from getting back into their communities, simply because they have a symptom of COVID that also is a symptom of their lupus. Just a couple of points about the vaccine. There's a ton of questions that we get about the vaccine, including whether it's safe and effective in people with lupus. Right now, by and large, they are, but we really defer those decisions to the physician and the patient to make those, taking into account their unique medical needs. But it also points to the need for more research to understand the safety and efficacy of vaccines in people with lupus and other autoimmune conditions. And a couple other things when it comes to the vaccine is a real importance of education and getting outreach and the importance of getting vaccinated, particularly in the general public. Lynn had mentioned earlier the need for herd immunity. The more people that are protected from COVID, the better it is for people who are immunocompromised. It enables them to get out into their community. So that education is critically important. And of course, for lupus, we want to make sure that people with lupus are prioritized. Right now, they are not, unfortunately. So we want to make sure that states and other policymakers really recognize the need for people with lupus to have access to the vaccine, as well as for their caregivers to have access to the vaccine. And then finally, I wanted to close with some additional solutions that we want policymakers to really take into account. In these, and I think you'll hear more about this too, but social determinants of health, access to care, whether that's physicians in your community, whether that's insurance, access to care is critically important. And some of the social determinants of health are important not only in lupus, but in a lot of other conditions. So that's critical. I mentioned awareness and education, not just about COVID, but about lupus and COVID. We do have a program at the CDC that is helping to raise awareness among physicians, helping to drive people to get a quicker diagnosis, and also to learn more about the challenges with COVID, how COVID is specifically impacting the lupus community. And for those of you on the Hill, working on the Hill, I will say that there is a dear colleague that will be circulating in the next week or so, supporting funding for this research. And certainly access to care, whether that's telemedicine with options for in-person. So telemedicine not only is important that telemedicine continue, and certainly when it comes to reopening, as I mentioned, we want to make sure people with lupus aren't unfairly discriminated against. And clearly more research is needed, particularly on those who are immunocompromised. With that, I will turn it back over to Lynn.
Thank you. Oh, there we have another picture of Monique, and introduce Nick Armstrong from the AIDS Institute to give his presentation. Thank you.
Great, thank you so much, Lynn. My name is Nick Armstrong. I'm the manager of advocacy and government affairs at the AIDS Institute. The AIDS Institute, we are a national nonprofit that began as a grassroots mobilizing effort in Florida in the mid-'80s. Since then, we've grown to do national policy. And like many public health and patient organizations, we've been really concerned over the last year about how COVID-19 is impacting our patients. For my part of the presentation, I was just going to do 3 main points, which is the impact of COVID on people living with HIV, the impact of COVID on HIV treatment and prevention programs, and then how we can take some of the lessons learned in the HIV epidemic and translate them into COVID response, especially in vaccination efforts. So like many disease states right now, there's still limited data about how COVID-19 increases risk for people living with HIV. When people are living with HIV and on medication, there's medications that are really effective. And when a person reaches what we call viral suppression, that means that the medication effectively suppresses the HIV in a person's system and really limits the impact on a person's immune system. This is important because it can allow someone to live a full and healthy life. And it also means they can't transmit HIV to a partner. Right now, the CDC has stated that folks who are virally suppressed are not necessarily at an increased risk for COVID-19, but only 56% of people living with HIV in the United States have reached viral suppression. And the structural determinants of health that have driven health disparities in COVID-19 are a lot of the same structural barriers that impact people living with HIV. So racial health disparities in COVID and HIV are really similar. In the US, Black and Latinx people are most impacted by HIV, especially Black and Latinx gay and bisexual men and Black women. People who are unstably housed, living in poverty, living in areas without access to a strong public health system are more likely to be impacted by HIV. And this is all confounded by the stigma associated with HIV that Janet mentioned previously in this presentation. And additionally, the people living with HIV are an aging population. Right now, over 50% of people living with HIV are over 50, and they have higher rates of comorbidities, which also increase risk for COVID-19. So as I mentioned, there's a lot of great treatments for HIV that are really effective, but they have unique needs for each of the patients, and those needs have been really impacted by COVID-19. Medication supply, people need to take a once-a-day pill or multiple pills every day. So we've had to work with folks to make sure that they can get more than 30-day supplies of medication, up to 90-day supplies, making sure that medications can be delivered to people's doors so they don't have to leave their houses and go to a pharmacy in person. Also, to treat HIV, you have to consistently monitor a person's CD4 count, which means that patients have to have consistent labs administered. And the COVID-19 restrictions have required that we have some flexibility in that lab monitoring. And importantly, in-person clinical visits between a patient and their doctor have really been impacted. Those clinical visits are when a person can really figure out what HIV treatment is effective for them. And those clinical visits have been transitioned to telehealth visits. And patients who are, especially in rural areas who don't have access to broadband technology, might not be able to get those telehealth visits. And finally, one of the successful parts of HIV treatment is all of the supportive service that HIV treatment programs provide to patients. So we're talking about those housing services, food and nutrition, transportation, mental health services, a lot of services that actually Janet and her organization provide to their clients. With the move to telehealth work, those supportive services have not been as on the forefront for our treatments. So when it comes to HIV treatment and prevention programs, we're really lucky in the United States to have a pretty robust public health system that works to treat and prevent HIV. The Ryan White HIV/AIDS program is a really successful program that's been around for 30 years now. And about half of the 1.2 million people living in the United States receive some sort of care through the Ryan White program. But this program, like many public health programs, have had to really adapt to COVID. We're seeing an increase in new clients to the program. Ryan White is a safety net program, so as folks are losing their insurance or losing their jobs, they're having to rely more on the services of Ryan White. They've also had to quickly adapt to telehealth services for their clients. Because Ryan White doctors are infectious disease experts, a lot of Ryan White clinics have had to have their staff go to COVID-19 response rather than doing the core HIV treatment work that they usually do. And a lot of Ryan White clinics are also duly funded, federally qualified health centers and are located in areas that are heavy hit by COVID. So a lot of these clinics are also doing on-site COVID testing. And then as people lose their jobs and employer-sponsored healthcare, the payers of HIV treatment has had to change as well. And then on the prevention side of things, many HIV prevention programs, especially those that are housed in public health departments, have also had to really adapt to COVID-19. They have been forced to limit or pause in-person HIV and STI screenings. There's a drug there's pre-exposure prophylaxis is a once-a-day drug that a person can take that effectively prevents HIV. But in order to get that prescription, someone has to have a HIV negative test and do other testing before they can get that prescription. So they've had to pause or limit initiations in PrEP. And 75% of HIV programs have reported detailing towards COVID response because they are public health programs. And we've also heard that 60% of HIV prevention programs receive some sort of state funding. So as we see potential budget shortfalls in state and local governments as a result of COVID, that could really impact HIV prevention programs. So HIV prevention programs and treatment programs have really been able to adapt and create some new and innovative ways to engage with patients and the community during COVID, but we still fear that they will lose contacts with some of our most vulnerable populations, and we could see an increase in new HIV incidences. And as the economic impact of COVID continues, many people who rely on these public health and safety net programs will increase. So as these programs are stretched thin, and they increase demand, possible increases in new HIV incidences, coupled with budget shortfalls, it really necessitates an increase in federal funding for HIV prevention and treatment programs. So we hope policymakers, especially in Congress this year, really help to rebuild and finally fund public health programs at the levels they need to properly treat and prevent HIV infections in the United States, as well as infectious diseases and the entire public health system in the United States. So finally, I just had a few points I wanted to make. There's a few lessons we've learned in combating the HIV epidemic that I believe can really help inform some of our responses to COVID-19, especially as we're doing vaccine distribution and rollout. Since the beginning of the HIV epidemic, we've really had to break down barriers that have prevented marginalized populations from engaging in comprehensive and effective care. And we learned that effective care and effective HIV care is not just medications. It's providing housing services, it's providing employment services, transportation. All of those have led to better care outcomes for our patients. And we also know that we can't just test and treat our way out of the epidemic. We have to really focus on eliminating disparities based on race, based on gender identity, sexual orientation, and of course, location of where someone lives. That must be a priority if we want to really end the epidemic. So as we are looking to roll out the COVID vaccine, a few things about communicating with vulnerable populations that we've learned in the HIV epidemic that I'd like to just discuss. First of all, the most effective HIV prevention and treatment programs are really catered towards the populations they're meant to serve. The HIV epidemic in New York City doesn't look like the same in rural West Virginia, but also the epidemic within the boroughs, between the boroughs in New York City doesn't look the same. And in order to make sure that our public health programs are really catered to the unique needs of those populations, the people who are most impacted really need to be giving their voices to this effort and really doing the planning. That means engaging with trusted people in your community, providing as many different programs and prevention options for people as possible. And we also need to meet people where they are so that we can provide the care in the communities when they need it and not just when the public health program is able to do that. So as policymakers are trying to roll out the vaccine, I encourage you to reach out to local HIV treatment and prevention groups so that they can help give some insights in how to best reach the community, especially while we're trying to combat vaccine hesitancy and engage folks who might not have been engaged in the healthcare system previously. So with that, I'll pass it back to Lynn and happy to answer questions at the end.
Thank you, Nick. I just want to say I'm going to be introducing Molly Guthrie from Susan G. Komen. We're running a little behind, so if we don't have time to get to the questions today, we will be emailing out answers to a lot of your questions after the briefing. So we'll try to get to a few, but we don't want to cut the speakers too short. So I'll pass that over to Molly now so she can give her presentation.
Thank you, Lynn. And I will be brief and to the point so that we can at least get to a couple of the questions. As Lynn shared, I'm Molly Guthrie, and I serve as the Senior Director for Public Policy and Advocacy at Susan G. Komen. And today I'm here representing the perspectives of the more than 284,000 women and men who will be diagnosed with breast cancer, the more than 44,000 lives that we will lose, and the 3.8 million breast cancer survivors today in the United States. Like many of the patient communities represented already during this briefing, breast cancer patients and survivors face significant challenges in maintaining their health and well-being. This is always true because of the physical and financial and emotional burdens that are associated with treatment. But this has been even more so true during the global COVID-19 pandemic. So in breast cancer, typically we see suppressed immune systems in individuals that are currently in active treatment, but especially those that have used or are using anti-cancer medications, immunotherapies, and or radiation therapies. Many of our patient advocates have noted increased anxiety during the pandemic when leaving their homes, in addition to having to go out to visit their healthcare providers, very similar to the amazing patient advocates that we heard earlier. COVID is also having a significant impact in the overall breast cancer landscape. So it's leading many individuals to delay screenings, including the breast cancer screenings that we've heard about for many years. So models that were based off of a 3-month period between March and June of 2020 have suggested that there could be as many as 36,000 missed or delayed diagnosis of breast cancer because of COVID-19. And unfortunately, these 36,000 missed or delayed cases often result in individuals that are not seeking care until their breast cancer is more advanced, which leads to worse outcomes for the patients and much more costly treatment. In addition to that, similar to what the other panelists have shared, we've seen significant disruption in clinical trials. So especially those in our metastatic breast cancer community, and for those of you that are not familiar with that group, that is individuals with breast cancer that has spread beyond the breast to nearby lymph nodes or to other organs in the body. And those individuals often depend on clinical trials for their treatment. And especially at the beginning stages of COVID-19, we saw stalls in those clinical trials, and some were even forced to stop accruing new patients, which really impacted the outcomes for women and men across the country. And we know that we need to get things back on track, both to allow for opportunities for care, but also the scientific advances that are right on the cusp of discovery. More recently, again, covered in the news, there were a lot of issues around access to the vaccine. Again, looking at the immunocompromised subset of the breast cancer population, they were not prioritized. Since rollout, expansion has happened in many states that are now allowing people in active care for breast cancer and breast cancer survivors to have access to the vaccine. And then most recently, There has been news about the vaccine and the potential of causing swollen lymph nodes and what that can mean for screening, which unfortunately we are concerned can go two ways. One, lead to people not getting the vaccine because they have a screening coming up, or not getting their screening because they just got the vaccine. And so doing a lot of education around that topic as well. Looking at if you'll go to the next slide, looking at potential policy implications that we can learn from here, again, to do this quickly and not repeat what other panelists have shared, similar to the two gentlemen before me. In the breast cancer space, we also have a prevention program at the CDC. Before COVID, funding for this program was only serving a small margin of the eligible population. And so increasing funding had long been a priority, but especially as we look at the fiscal year 22 appropriations, knowing what I just shared, that there's been a significant delay in screening. But also if you look at the economic impact of COVID, unfortunately, the job loss has predominantly impacted women. And so for any of those women that had lost their job, if their insurance was employee sponsored, there will likely be a larger eligible population for this program. Additionally, in the breast cancer space, there are newer therapies that are available in an oral form versus IV. But the insurance design behind that often leads to patients having to pay significantly higher amounts for the oral agents as compared to the IV medications. And so for many Congresses, we have had legislation introduced that addresses this disparity. But in light of COVID, something that we should especially look for creating parity in that coverage, so patients have access to all options, or even just the one option that might be in an oral form. And then last but not least, again, talked about many times already this afternoon, is how we can take shared learnings from telehealth and telemedicine and continue that post-COVID, while also addressing, issues of limited broadband access, knowing that not all individuals have that option, but not having the advances that we've made in telehealth and telemedicine, and as a result of hopefully one day moving past the coronavirus. So very, very quick, I'm happy to answer any questions, but thank you for the opportunity. And Lynn, I'll pass it back to you.
Thank you. So we could probably do a question or two. And like I said, we'll answer other questions by email. We're going to notice our website here. We're going to have the presentation eventually posted on there. We have a fact sheet posted on the website now. And we got a few questions about the monoclonal antibodies for those who don't respond to vaccines. And I just wanted to say, well, number one, we're not physicians, but currently I know the CIS, the Clinical Immunology Society, is doing a survey on people with PI who have been vaccinated, and they're going to be, looking at that response. And if people test positive for COVID, their physician can get them access to that. But it's not available right now for preventative because there's not a recommendation yet in that. So are there any other questions, Jamie, for me to send to the panel?
Hey, Lynn, sure. Yeah, we got a great question from Kathleen. Kathleen asks, how does the FDA address those who are negative vaccine responders?
Again, we're not, it's something we have to look into further. I think, this is an issue that we're advocating for in terms of making sure that people have protections that they, need even, and that why herd immunity is so important. So these are, part of what this group is advocating for. Pat, do you want to chime in?
Yeah, I was just going to say, some of the questions that I've seen, including that one, really point to the need for more research in both, whether it's vaccine or COVID, in these populations. Because there's a lot of things. There are a lot of things we just don't know the answers to right now, or there's speculation. It really points to the need for more research specific to these populations.
Absolutely. And one thing that I know the Immunodeficiency Foundation is doing, and others as well, are doing surveys and finding out from our populations how they are responding, whether it's to the vaccination, whether they're getting COVID, and what the responses are, so that we gather data and are able to, have scientific responses to these kinds of questions.
Absolutely. So this is a question and also a bit of a call to action. So I feel like this is a good way to wrap us up for those of us that are in the audience from congressional offices. I would like to know if our legislators can make their constituents aware, maybe by public service announcement, that they can help us by donating plasma to their local plasma centers and let them know where those centers are located. So just wanted to close out on that, and any comments our panelists may have in response to that question.
I agree. I think that would be great. And we'll be reaching out, all our groups are reaching out to our legislators to share our concerns, and just want to give a pitch that our collaborative, the broader collaborative, is going to be being more active. Anybody from any of these groups that are impacted as being immunocompromised, please email me if you want to join our monthly calls, and you can get engaged in our activities in this area. So I think that's a good way to sign off. Thank you all.